Welcome back from break, everybody. Kathy, I will turn it over to you.
Thank you very much, Melissa, and welcome back, everyone. All right, let me get our slides back going again. All right, so let's move on talking about a few more complex situations. We'll talk about persistent nipple pain since that came up next. And we might be able to work in a little vasospasm into that conversation. I'll switch over there and talk just a moment about it, at least, so we at least touch on it, because I know a lot of you mentioned that one as well. So we know this is the picture that I believe we saw a couple of days ago in our assessment skills section. This is a breast that is experiencing quite a lot going on here, and this mother was in a tremendous amount of pain. This nipple has a bit of a biofilm that has already started forming over some of that infected area. You can see evidence of some dry blood there, that dark reddish brown blood, that's kind of that old blood, and it's already started to dry and probably scabbing, going to be scabbing up here in a minute. A lot of redness all around this area. We see that red ring kind of all around this breast, which to me indicates maybe a poorly fitting flange or improper use of a flange. And that actually could be a flange that was too large, where the entire areola is being sucked into this flange. And so that could be something that might be going on. Maybe it has to do with the bra that she's wearing, except that I see that ring going all around. So that's what tells me that it's a flange. It could be a mother that could be redness from wearing a breast shell, and either it's really not fitting her properly, or she's not using it properly. Maybe she just took it off, but a lot of redness there. I don't know if anybody else has any ideas of what might be causing that redness. I'm thinking even infection might be spreading, and that could be causing that as well. So could be a lot of things going on. We know that physical sign of persistent pain might be that we see these open sores like we see in this breast here, or evidence of bleeding, signs of infection, which would include pus or fluid, or sometimes that crusted over area. Sometimes we see kind of a yellow crusted area. The parent might be running a fever. All of those could potentially indicate some kind of a nipple infection. There could be rashes of various kinds, or maybe little red bumps that you see sometimes with a candida infection. Keep in mind, of course, that on darker complected breasts, it may not look that way. You might see pus, you might see crusted areas. The breast might feel warm to the touch, something along that line. You might see cracks and bleeding, but you may not see the redness. So again, be very careful that you don't discount the experience of any mother who comes to see you. She says it hurts, breastfeeding is painful, and you look at her breasts and you don't see redness, you don't see anything. That doesn't mean she's making it up. So believe her if she says it hurts. Let's figure out what else might be going on and try to ask more questions to identify other issues going on. Nicole said maybe the shiny part of her breast might be due to lanolin, and that's a very good point there, Nicole. That could be a result of lanolin, or it could be the result of a medicated ointment that the doctor has prescribed for her. I would hope that this mother has gotten some medical treatment, because I'm seeing the potential signs of infection, and we would definitely want her to be getting some medical treatment. So many of those topical ointments that a doctor may prescribe can leave that area looking very shiny. So that could be what's causing the shininess, or it could be, something else going on. Let's take a look. But first of all, before we take a look at some causes, let's build another resource for all of you to work for. And on this resource, I want you to just indicate everything you can think of that might potentially cause nipple pain. Let's just see if we can get a really robust whiteboard here of everything you can think of that might cause persistent nipple pain. So when we talk about persistent nipple pain, that would be pain that we've already corrected the latch, the positioning, and the mother is still experiencing pain despite those early efforts to address it. All right, baby developing teeth. Okay, thank you for mentioning that. Sometimes when babies begin teething, even before the teeth erupt, we can see some poor feeding practices that start happening right around then that can be a problem. And certainly when the baby has teeth, that can interfere. Poor latch. So it could be that even though we've corrected positioning and latch, the mother is still, feeding the baby in an incorrect way, or the baby is still going back to old habits. Tongue-tied, very good. Infection will cause pain, absolutely. Thrush, maybe it's an older baby practicing gymnastics. I love that. Thank you very much. That's a term I've always enjoyed using with parents. So older babies do get into a lot of weird positions, and you just have to go with the flow, don't you? But that can cause pain. Infection, injury, okay, those are all good. What else would cause persistent nipple pain? Okay, I believe you're trying to put clogged milk duct, and that very definitely can be happening, especially if we also have a nipple bleb that is going along with that plugged duct. Nipple blebs can be extremely painful, and they don't resolve until you resolve the bleb. Vasospasm, yes, thank you, Raynaud's, which is the syndrome or the phenomenon, and vasospasm is what the nipple does when somebody has Raynaud's. And we'll talk about that in a moment. More sensitive to new cosmetics, lotions, body wash, etc. So very good. Thank you for mentioning that. That's one of those more common issues that nobody ever thinks about. But just pausing to say, hey, are you doing anything new? Are you using, a new perfume or body wash, or maybe even the detergent that they're washing their bra in that is causing some issues? So don't rule that out. Wearing clothing that's too tight, and that might include wet nursing pads, keeping our nursing pads too moist. That can definitely cause issues. Skin breakdown, poor fitting bra, torticollis, yes, torticollis, and I would add plagiocephaly to that list as well. Can cause nipple pain, skin conditions. So yeah, that could be anything from eczema or psoriasis to something more serious like shingles or anything along that line. There can be a lot of skin conditions. And as WIC staff, unless you are a practicing physician with MD or nurse practitioner after your name, we cannot diagnose. We can't say, well, that looks like shingles to me, or that looks like herpes to me. You have to tell them. I mean, you can say that I have seen some people with lesions similar to yours that it kind of looks like herpes to me, but I'm not a doctor, and I really want for you to have that diagnosed by a physician. Lip tie as well as tongue tie, thank you. Improper flange fit, thank you all for adding that to our list. Nipple feeding, yes, a baby who is just feeding on the nipple. Anything else? Kylie said painful scar tissue from past piercings. That's a very interesting suggestion here, and I have not personally had any experience with anybody who experienced pain from that, but if anybody else has, put that in the chat box. Let's share those experiences that potentially could be going on. Let's also add to our list a baby issue like a receding jaw. You fix the positioning of the latch, but the baby's jaw just cannot come out sufficiently. So receding jaw, or maybe a baby with a bubble or a high palate, some kind of a palatal issue, can definitely cause pain at the breast. I don't see herpes on the list, but that could be considered a skin condition. But let's go ahead and add that one as well. Just trying to think if there's anything else in my mind. Do we have Candida on here, or a yeast infection. I don't see that. Let's add that to our list as well. And one more that comes to my mind would be a baby who just has a sucking disorder. Sometimes babies have weird ways that they suck, and maybe they clamp down on the breast really tightly, and for whatever reason, it could be due to a tongue tie, but sometimes there are other conditions that may be going on. Well, thank you all. Anybody else have anything else you want to add to our resource list here? If you do, now is your time. And I tell you what, Melissa, if you can export this for our document, that would be terrific. But rather than Xing out of it, I'm going to leave it minimized, but you should still be able to access it even though I've minimized it, maybe. And if you can, you could still add a few things to it. So I'll leave it minimized for a little bit longer. All right, so here are a few pictures of some conditions, and I want you guys to come to chat and tell me what you think has caused this condition. And in all of these cases, these mothers had extraordinary pain. So anybody know what this is evidence of? Yeast, perhaps? Looks like scabbing. This is actually a biofilm. This is an infection. So this is a nipple that formed a pretty severe biofilm. And in this case, it was kind of a yellowish color, but also look at all the redness. And some of you who guess it might be thrush or yeast might be looking at all those little red bumps. And it could have started that way, who knows? But definitely this was a very severe infection. But good guesses, everybody. And I think I would have started with nipple thrush as well. What about this one? Any thoughts about what this one is? We actually have seen this one already, so we'll see if you all remember it. Karen asked, how can you tell the difference between biofilm and scabbing? Karen, I don't know the answer to that question. I will say usually when I've seen a biofilm, it's in early stages, and I've noticed in early stages it tends to be more like a thin, whitish, grayish colored, clearish even. It's just like a little film that, it's just the best way to describe it, just a little film that sort of appears over that infected area. I've actually had a couple of biofilms in other parts of my body. I had a little papilloma on my leg that had to be removed. It was very small. It had to be removed. It wasn't cancerous, but it was like a basal cell carcinoma, like a precancerous type thing. And the dermatologist removed it. And when she did, it did get infected. I tend to have a lot of issues with infection on my feet area. Maybe that's because I'm tall and I'm not sure what it is, all the gravity, who knows. But it did form a biofilm over it. And so I have a little personal experience with a biofilm. And when I saw that kind of clearish, grayish, like just a little thin film that formed over it, I went, oh, I've got a biofilm. And I called the dermatologist back. I sent her a picture. She said, yep, you're definitely infected. And she prescribed an antibiotic. So that's been my personal experience. And I've had several mothers who had a biofilm, and fortunately they got help early enough that we caught it. I would suspect that if it isn't caught early, then you would have it start looking more like that scabbing. So you could even ask that mother with that yellowish crested thing, what did it look like before it got to this? That might be helpful to kind of understand the stages that she went through. All right, and this is not mastitis or a plug duct, although we suspect that it might be. Any other thoughts about what this picture might be? Oops, I'm so sorry. This is thrush or a yeast infection, a yeast overgrowth. And unfortunately, it just tore her skin up. Look how raw her skin became. And you do see some of that. Sometimes you do see that yellow crusted stuff stuff with yeast. That's why everybody was a little confused about that first one. But look at all the redness it caused. We also have all this redness around the areola, which again, I think might be pump trauma, but it could also just be exposure, that area of her skin having more issues with the yeast in that area from her bra or the pump flange or maybe breast shells that she is wearing. Really uncomfortable, and this parent in a lot of pain. Kylie said, was it a chemical burn? And that would be a good guess to ask, Kylie. I love where your mind was going with that. So when you see patches like that, let's find out. Let's just ask questions if she had ever experienced any accidents, or does she know what causes this? All right, let's take a look at this one. Anybody know what is causing the pain this mother is feeling? Kind of looks like that biofilm we talked about. Pump trauma, perhaps. And you might be thinking about the darker area around the edge of the areola, perhaps might be some pump trauma. Any other guesses as to what this might be? Baby latching only onto the nipple. That would probably be where my first guess might go, that this baby is doing a lot of nipple feeding and that this is some skin breakdown. But actually, what if I told you there's no trauma to the breast whatsoever? What would you think might be causing this appearance? Raynaud's. Yes, thank you, Alicia. This is what Raynaud's would look like. So with Raynaud's phenomenon, which is a syndrome that sometimes affects people who have autoimmune disorders, sometimes what happens with that is that the extremities can be affected, especially when they are exposed to cold. And in many of these cases, the nipple, which is kind of an extremity, would constrict. So basically the blood vessels inside the nipple area constrict really tightly. And when the baby is through with the feeding, and now her nipple's exposed to cold, the nipple becomes very pale, very blanched. And then as blood begins circulating again in the nipple, it will turn kind of a bluish cyanosis. You can almost see a little bluish cast to this nipple. This nipple is not totally white, but it's beginning the process of turning blue, purple, and very, very red. You'll see that especially in very paler skinned people. And people report that the pain is excruciating. And I do want to show you a picture. One of a lactation consultant in one of our trainings sent me some pictures, which I really like because it really shows the stages in her hand. She was well past the idea of breastfeeding. Her children were already grown, but she developed Raynaud's and she experiences it in her hands. So anytime her hands are exposed to cold like this or stress, they turn very, very white like this. And then they become very red, and eventually you see they're transitioning from white to red to more of a purplish, bluish color before then eventually they get back to its original color. So very important information for us to be aware of. Ask people, what does your nipple look like before the feeding? Does it look any different after the feeding? And I'm reminded so much of a story of one of my peer counselors who had Raynaud's, and we didn't know what it was. And I was a brand new lactation specialist at the time. I was not an IBCLC yet, didn't know very much, and we didn't really know very much about Raynaud's at that time, or that breastfeeding women could get it. So in fairness to all the people she saw, but she complained to me that breastfeeding felt like, she said, like needles, just sharp needles were, radiating all around her nipple. And she wanted me to observe her nursing. Well, she had fed 4 other children, and she said she experienced this pain with every one of her children. And she did tell me that she had lupus, and I just ignored that information. It didn't even occur to me that there was a connection because I didn't know anything about it at the time. And I remember observing her, and I'm thinking, wow, the baby breast is latched perfectly. There's nothing I would fix. I thought, well, maybe she has some intraductal candida, although now science has disproven that people don't get thrush inside the milk ducts like we thought they did. But she did go to a doctor. She did try antifungals. Nothing helped. She tried that with 2 or 3 children, and she finally just decided, I just have to live with it. And she said, the pain doesn't last forever. Just it only hurts after the baby comes off, but then it gets better. So I sent her to a lactation consultant friend of mine in New Orleans, who I consider to be one of the brightest and best LCs I've ever known. And unfortunately, she has passed on since that time. But she'd made the trip all the way down from North Mississippi down to New Orleans. And this person looked at her and called me later and said, she's just making this up. I mean, I can't see anything that would be causing this pain. And she had nothing for her. And she was very distraught that she got no help. And eventually then we were at a peer counselor meeting, and she was nursing her baby. And when the baby came off the breast, she said, oh, Kathy, I hate to interrupt you, but look at my nipple. This is what it looks like after the feeding. And when I saw her nipple was white, I went, oh my gosh, I have heard of this. I couldn't remember the name of the condition, but I knew it was a vasospasm. And I said, oh my gosh, I think we have figured out what you have. I then did some research at that point and learned about vasospasms. And I felt sorry. I felt so bad that for 5 children, nobody ever told her. So I just want to make sure everybody's aware. If you've never seen that before, that's what it might look like. And be aware that there are solutions. Primarily, we would recommend warmth, maybe having the temperature on in the house a little warmer, as well as maybe having that heating pad or a warm blanket around her, and then having a warm compress. Immediately put that warm compress on the nipple immediately after the baby detaches from the breast. And there is a medication that can be taken for people with lupus that does help with this. So she could talk to her doctor about medication that she could take. So just want to make sure we did address that. Anybody know what this is? We should all know this. Yes, this is a nipple bleb, also excruciatingly painful. It looks like a little blister, and a lot of people ask about just taking a needle or a safety pin or whatever and just, poking that. And we don't recommend that for obvious reasons. That is not a sanitary practice, and that can open the skin and cause a portal of entry for bacteria. So sometimes babies will open it themselves. And if they do, then I usually tell a mom to at least let her doctor know that it has now been open, and is there anything they should be watching for or looking for. And I've had some doctors prescribe an antibiotic cream that the mother could put on that area if it has been open. But if she cannot, the baby doesn't open it, usually coming to the doctor or the nurse practitioner can open that in a sterile environment. And boy, people experience like immediate relief once that is open. But we never want to do that to her, and we don't want to recommend she do it to herself. All right, anybody know what this is? And this is a lighter complected breast for sure. So you might not see this on darker skin. Again, please, please, please refer to your melanated mammary atlas, so you're very familiar with what some of these conditions look like in other people. So everybody says mastitis, and actually it would be on the spectrum to mastitis, but it isn't mastitis. This was a plugged duct, or I would venture to guess, the person who told me it was a plugged duct, I'm going to guess that this was probably inflammatory mastitis. They said, well, she wasn't running any fever and there weren't any other signs of mastitis. Baby was nursing fine. She did have a lumpy area that was very painful to the touch. So they assumed it was a plugged duct, and it could be, but it could also have been inflammatory mastitis, that it just hadn't gotten bad enough to need an antibiotic. And what about this? This is a very deep fissure in the nipple that, so the skin has been broken down by something. I don't see any redness here, so apparently this is healed pretty much, but we still see some pretty badly macerated tissue. So what do you think might have caused this? Yeah, ouch is right, Rebecca. I agree with you. Oh, piercing maybe. Oh, very good question. I don't know. I'm not seeing a piercing, but that definitely could be something we ask about. Maybe a bacterial infection. It could be that this was started by a bacterial infection. Myrna, says nipple trauma, and that is what was going on. This was nipple trauma. Biting, Heather says, no, actually was a younger baby. This was actually the result of a baby with a tongue tie. And this is what the nipple ended up looking like as a result of not being able to pull the nipple into far back into his mouth. So let's talk about our assessment. Obviously, anytime somebody talks about persistent pain, we need to do a breast assessment. And you want to think critically, just the way you guys have been doing. You guys are amazing, and you've had some really good suggestions in the chat box. So think about all the possible things you've been trained on and your experience has shown you what possibly might cause that. And if you don't know about some of these conditions, do a little further research on your own. Go to some of these textbooks we mentioned yesterday. Go online to some of the online conferences like GOLD and ILCA and USLCA, NWA. There are a lot of fantastic presentations that are now archived where you could learn a little bit more about some of these conditions. And for those of you who want to know more about DMER, dysphoric milk ejection reflex, I know GOLD has had a couple of archive presentations on that, and ILCA has as well. So you may be able to go to the Knowledge Center at ILCA's website and find a presentation on that topic. You're probably going to want to observe a feeding session just to see, maybe rule out feeding problems. You may need to do an infant assessment. And you also want to assess any practices, like how often they're feeding the baby, what else might be going on. And your tips for dealing with nipple pain, obviously we have to, whatever the root cause of the pain is, we have to start there and provide solutions specific to that. But you're going to want to find out more about, when this pain actually began and, how long they've been dealing with it, and provide very specific solutions. I will say for a baby who has a bubble palate, because you might be wondering, we mentioned that, what do you do about that? The key with the baby with a very high palate is to try to get them to put to get a deeper latch and get more of the nipple and the areola into the mouth. So this mother is doing a sandwich hold. And I believe we may have talked about this in level 2, where you place your thumb on top, your fingers underneath, and you make sure they're well away from the nipple and the areola, but you just bring the breasts together. You just compress them as close together as you can, creating a sandwich, so to speak. And this allows the baby to get much more breast tissue into their mouth. That's one of my best suggestions for a bubble palate, just to try to get as much as possible. I also often recommend doing a laid back breastfeeding so the baby can use gravity to get much more into their mouth. All right. Any other suggestions anybody has, feel free to drop those in the chat box. The other thing I just wanted to mention regarding nipple pain and persistent pain and infections is, for years and years and years, we always said, never wash the nipples with soap and water. You always use plain water on the breast. And I'm going to tell you that I heard Kay Hoover, who's a very well-respected, renowned educator up in Pennsylvania. She did a presentation at ILCA maybe about 3 or 4 years ago. And she challenged that notion. She said, where's the evidence that says we should never wash the breast with soap? We wash our breasts with soap all the time before we get pregnant, right? We wash our body with soap. If we have an infection, doctors often say, wash that area with soap and water to help, minimize infection. Why are we passing on information that we don't really know for a fact is evidence-based? And I haven't actually found any research that says, I find lots of guidelines like never use soap, but I haven't found any studies that say you should never use soap, like a peer-reviewed study. So I would say on that issue to just think about that and do some of your own research. And let's just be sure any suggestions that we're offering to parents, we're not offering because that's just how we've always done it. Let's make sure there's actually evidence behind that. But Kay Hoover suggested she thinks washing an infected nipple with soap and water is actually a very good thing because there was plenty of research to show that that is effective whenever somebody has an infection in another area of your body. So we probably do want to avoid perfumed soaps and things along that line, but using a plain soap to help wash that area is probably not a horrible suggestion. So I'll throw that out there as just something to keep in mind. We have to keep up with our knowledge. So let's talk about this spectrum of mastitis, and then I think we'll have to take our break in about 10 minutes. And again, whatever we don't have time to talk about, you've got your handout, and we do have some self-study videos that go through all of these topics as well. So there are other ways to get some of this information and to refer back to. You may find later, what did she say about inverted nipples? I don't remember now what she said or what she say about that. You'll be able to go back and review some of that information other ways. And Rachel will share more about that at the end of the day. So I want to point you to the ABM clinical protocol. It's protocol number 36, and it's called the Mastitis Spectrum. And it was published in, believe it was in August or maybe September of this past year. And it's this protocol has taken the lactation world by storm because it has debunked a lot of the common myths and things that we have been recommending about mastitis and engorgement and plugged ducts for many years. And it's really challenged us in the field to think about things in a little different way. If you have not read the protocol, Melissa has just dropped that link into the chat box. I want to invite every one of you to download that protocol, read it again, read it a third time, take your yellow highlighter and go through and highlight things that are new to you and things you want to make sure you remember. So I'm going to kind of review for you a few things, a few highlights in this protocol. And I want to give you one quick little caveat to this, and that is to remember that ABM's protocols were designed and written for providers. Now, the lactation world uses them, and they're certainly fine for us to use. But remember, some of their recommendations are not in our scope of practice. So for instance, they talk about when an antibiotic would be needed and when an antibiotic should not be used. And they talk about which antibiotics are appropriate for different types of mastitis. That is not our scope of practice, folks. So, but what I would recommend is that you make sure the providers in your network do have a copy of this protocol. And if you have a mother with mastitis or you suspect it's mastitis and you are making a referral to that provider, pass along this protocol. Let them know this is fairly new and a lot of physicians don't have it yet. This protocol was written by physicians for physicians. And these are all physicians who, the most part, are also lactation consultants. Many of them are MD, IBCLC, so it's a very illustrious group of physicians. When you look at those names, you'll recognize a few of them. So they talk about mastitis as part of a spectrum. And they say that oftentimes it begins with engorgement that is not treated effectively. So we already talked in level 2 about the comfort measures a peer counselor can offer a mother with engorgement. We talked about how important it is that we provide very quick care for engorgement, because if we don't, some things are going to happen that are going to lead to low milk production. One of the things that can happen with engorgement is engorgement, remember, isn't just about milk. Engorgement is not only excess milk that maybe is not being removed effectively, which then can lead to inflammation in the breast. So we've missed a feeding, so we've got a little extra milk floating around, but now also we have inflammation as a result of that extra milk that was not removed. And then in the early days, we may have issues with lots of inflammation as a result of IV fluids. And we may have inflammation as a result of just the normal process of when the milk begins to transition into lactogenesis 2. So during that process, there's an increase in lymphatic fluid. So this fluid, which isn't just milk, can become very painful if it gets too much. And if it is not addressed, it can lead to some problems. So one thing that happens inside the glandular tissue is that the lactocytes themselves become overfull of milk, and the amount of milk exceeds what the storage capacity is able to hold inside those lactocytes. And remember, the lactocytes are the cells that make the milk. But in addition to that, we see that the lactocytes become sort of distorted or warped, maybe would be another way of putting it. Where as they become more misshapen as a result of that excess fluid and all the excess milk, now the hormone receptors also become distorted as well. And once the hormone receptors become distorted, once milk is released, when the hormones of prolactin and oxytocin are released, they can't really get into the breast tissue through the receptors. So now we have issues where not only is the mother uncomfortable and maybe the baby can't latch, but now we have some real problems going on because now the mother's body is not able to use the hormones. So now we may have an issue with a decline in milk production. In addition to that, we can have an issue with blockages that can occur. We can also have an issue with an increase in the number of little whey proteins that build up inside those lactocytes. These little whey proteins are called FIL, feedback inhibitor of lactation. I like to just think about the word FIL, FIL, that these little lactocytes fill up with these whey proteins. And those little whey proteins slow down milk synthesis, and they send the message to the body to not only slow down milk production, but also let's start dying off this tissue. We don't need this tissue. We need to get rid of the tissue. So the body, in a sense, is trying to protect this parent from this discomfort and the fact that this milk isn't being used, the milk isn't going out and being used. So it just sets up this cycle of problems that can grow into even greater problems. Now, according to the mastitis protocol from ABM, they say that when, I'll go back to this picture here maybe, when there is inflammation inside the breast area, that what happens is the milk duct itself, all of those milk ducts within the breast become narrow. And they're shrinking up. And as they shrink up, now the milk really cannot flow freely through those ducts. And as it gets worse, the inflammation gets worse. Sometimes we can have actual blockages, like a plugged duct that can occur. So that's why we're talking about this spectrum, how we start with one thing and things can very quickly take a turn for the worse, as now we have a blockage. And the mother may think, oh, my only problem is this plug, but actually the problem is much bigger and more involved than just this one little plug. That can then develop into what is called inflammatory mastitis. And mothers can have some symptoms of fever and chills, and they may have redness on the breast. That's why that picture I showed you, that the person who sent me the picture said it was not mastitis. I kind of wonder if it was actually inflammatory mastitis. She didn't have fever, but it was very, very early stages, potentially. All right, it's time for our last break of the day and our last break of this entire training series that we have enjoyed doing with Washington. So if you would, please be back on time. It is 11:20 your time. Please return at 11:30.
Welcome back from our very last break. Kathy, I'll turn it over to you.
Thank you. Oh my gosh, you're going to make me cry. This has been so much fun working with all of you, and I'm going to miss being able to interface with you the way we have this week. This has been just a really rich and wonderful experience to be with all of you this week, and I'm definitely going to miss the folks from Washington. Quickly, a few things I want to make sure I squeeze in before we get to the end. If a parent is experiencing unresolved engorgement, way back there at the beginning, the peer counselors offered a few tips. They're not really helping, or the mother's still experiencing a lot of pain and makes that referral. Your primary task is going to be to help them to encourage the milk to flow while also helping to drain that excess fluid. So this is where you're going to want to recommend therapeutic breast massage and maybe reverse pressure softening to get the baby to latch a little more effectively. Help her with deep breathing exercises, things that will help her to relax and lower her stress levels. We want to offer warm compresses right before the feeding. And the ABM protocol is very, very specific. Repeatedly, they say that the importance of using ice. And they actually recommend using ice every hour or so between feedings. We do still recommend warmth right before, like immediately before the feeding, because that simply helps the mother to relax and it will help the milk flow more easily. And we may need the milk to flow well as well. But other than that, if we're just treating the mastitis, warmth is not really a recommendation for treating mastitis, but it is going to be helpful to get the milk to flow. But the ice is what is going to help reduce inflammation. So they do recommend ice at least every hour. And that could be a bag of frozen peas or corn or black-eyed peas or whatever, suits your fancy. But honestly, what a lot of hospitals are using for ice packs for moms who are breastfeeding is they'll just take a disposable diaper and they open up one end of the diaper and they put ice inside the diaper. So I think that's an easy solution, and everybody can access disposable diapers, hopefully, particularly those little newborn diapers are small enough, but they're just about the right size to kind of wrap around the breast, which that's the one thing I like. It wraps around the breast. So you might want to consider offering that as a nice little ice pack to help reduce that inflammation. Another thing the ABM protocol specifically talks about over and over again, and this is where our curriculum is actually already out of date, because the recommendation we put in this curriculum, if you see this anywhere, ignore it. We're hoping we can get this FNS to agree to update this. But the curriculum says to keep the breast well drained. And ABM now says, no, the goal is not to keep the breast drained, because one of the major contributing factors to mastitis is overproduction of milk. And rather than keeping the breast drained, it's better to watch the baby's feeding cues, feed the baby when the baby needs to be fed, and only use pumping or hand expression afterwards for a particular purpose, like we are needing to rebuild milk production, or the mother is so much pain, even after feeding the baby, that she cannot, just cannot tolerate. She has to get some of that milk out. So in that case, you would do a little bit of pumping or hand expression, not enough to drain the breast, but just enough to alleviate the intense discomfort. Now, if these issues, we've helped her with this and it's not helping, and she's now moved on into mastitis. Just a couple of points about mastitis. Mastitis can begin as a result of bacteria that enters into the breast through some kind of a fissure or some kind of crack in the nipple. So basically, if there's an abrasion on the nipple area, that becomes a portal of entry for bacteria. And essentially what's happening is like cellulitis. We live with staph on our skin all the time. And most of the time, if we get a cut or a scrape, nothing happens. But sometimes we never know really what's going to trigger. Sometimes the environment seems to be just right for cellulitis to develop. And again, there's a portal of entry and staph is entering in, and it can cause a problem. Now, the ABM protocol says while that can be a cause of mastitis, it's probably not the most common cause. They believe the most common cause of mastitis is not dealing with engorgement way back at the beginning. So as I mentioned, they talk about two different types of mastitis. One is the inflammatory mastitis that may not require antibiotics to treat. So we would resolve inflammatory mastitis with some of the usual things that we would recommend for engorgement, keeping the mother comfortable, helping her relax, helping the milk to flow, feeding the baby on cue, not overfeeding. I will say this: if you have a mom who's already been overfeeding, and maybe she thinks I've got to pump and pump and pump to feed my freezer, so that I have plenty of milk for when I go back to work, that actually creates a problem of overfeeding. Another issue that can cause that are those sweet little, very inexpensive little vacuum suction devices that everybody thinks they have to have now. And a lot of mothers will put those suction devices on and they leave them on for very, very long periods of time. And they do work. I mean, I'm not going to deny they aren't helpful in allowing milk to constantly be dripping and draining into it, but it does set up a cycle of hyperlactation, and that can make edema even worse. So, but we would not recommend that a mother just stop using it cold turkey, because that would lead to problems as well. We would want to help her on a process of down regulating her milk supply so that she truly is just following her baby's feeding cues to eat. And, if there's a time of day, she's going back to work and there's a time of day where she feels she has more milk, maybe early in the morning, there's nothing wrong with her doing some pumping after feedings early in the morning and putting that extra milk in the freezer. But the issue we're seeing is people who are overly pumping or overfeeding or working to try to get every single drop out of milk all the time, or using one of those devices that leads to hyperlactation. So ABM says the primary cause with mastitis is overfeeding or production of milk. So if it gets to the point that the parent is developing, high fever and chills, and there is redness and her breast becomes very warm to the touch, and now the baby's refusing to latch because the sodium levels have gone up. That's what happens in an infection. The sodium levels go up, and a lot of babies don't like that. They won't latch. If all those things are happening, and then it could be that it actually is a bacterial mastitis, and only the doctor will be the one to be able to determine that. If that is not treated well, maybe they put the mother on an antibiotic and she doesn't finish it. A lot of people, after 4 or 5 days, they start feeling better and they stop taking their antibiotic. Then that can cause the resistant bacteria that weren't killed off right away. An antibiotic will kill off the less resistant ones first, and that usually is what helps everybody start feeling better. But those resistant ones will multiply themselves rapidly and create an even greater problem. And that can progress into an abscess where we have a collection of fluid that's going to potentially involve and require drainage. So ABM says solutions for mastitis, again, rest, decrease stress, resolve the early inflammatory mastitis through all the methods we've already talked about, decrease inflammation with ice very frequently, at least every hour. And they do say over-the-counter pain relievers may be okay as the doctor recommends them. So again, we would defer to the provider. They also recommend lymphatic massage and drainage, and they actually in the protocol have a lot of pictures that explain how to do that. And we've already gone through that training yesterday, so you now know how to recommend that. And they do recommend in their protocol that in some cases, sunflower or soy lecithin, around 5 to 10 grams each day, can reduce inflammation in the ducts. And it can also emulsify the milk. Sometimes parents have very thick milk that is, and especially when you develop mastitis, the milk can become really, really, really thick and even clumpy. I'm going to show you a couple of pictures somebody sent me of their clumpy milk that they developed during mastitis. I think I have pictures. Yeah, here we go. Somebody, one of our training sent this to me. She had twins, and after those twins were born, she did develop, she was pumping one day for them and noticed that her milk, look how thick this milk is, really, really thick milk. And she noticed that the milk was actually coming out in clumps. And they're kind of yellowish, greenish clumps of milk. And she did ask, she was a lactation consultant, she asked that her doctor actually analyze her milk and take a look at it. And they did find staph. This is another picture of big old clumps in her milk. She did take that lecithin, 5 to 10 grams daily is what the ABM protocol recommends. And she took that and she continued with her antibiotic and it cleared up. But here's the good news. It is okay to breastfeed, even if you have clumpy milk. The ABM makes it very, very clear that mastitis is not contagious. We're not talking about the milk itself being infected. It's the tissue that becomes infected. And actually what's happening, they mentioned in their protocol, which was kind of blew me away, is that those little biofilms that we talked about earlier, those can actually form inside the milk ducts themselves. So the duct can form biofilms. And so you've got this very small duct to begin with, and now it's shrunk really, a lot. Milk can't flow through it. Now we have biofilm forming inside of it. And again, it's not contagious, but it can be very, very painful. We know infections are very, very painful. So I hope this is helpful to you all. And I want to remind you, even though lecithin is over the counter, we cannot recommend that to a parent, but I would really recommend that you share that information with the provider because it could be a really great solution for a mother who gets persistent plug ducts. It just won't clear up. That can actually be due to a very thick milk that isn't clearing up easily, and it's not flowing through the milk ducts very effectively. Guys, our time is just about gone. We aren't going to have time to talk about everything, but I do want to make sure that we at least touch on babies who don't latch efficiently. There's a lot of problem areas here that we just don't have time to get to, but I think it is important. As a DBE, you will be getting lots of referrals if you're just now beginning this from peer counselors who say, I cannot get the baby to latch. We know there can be a lot of kind of a range of what the baby may experience. Maybe the baby latches, but just can't stay on the breast. Maybe they latch and form, kind of fall off the breast into a shallow latch. Maybe they get on, but they just can't form a very good seal at the breast. Or maybe they refuse to latch. They arch their back, they scream, they push away. Or maybe they latch and the parent says, no more, this hurts too bad. So there are a lot of potential causes of that. And part of your job as a DBE is to assess the baby as well. So I wanted to make sure we at least touched on this. One cause of a baby having trouble latching is oral aversion, where maybe the baby was suctioned quite a lot in the hospital, even one time of suctioning. For some babies who are very sensitive, this can trigger a vagal response, and the baby, and the baby can be orally defensive. So like they don't want the breast in their mouth. Sometimes they don't even want a bottle nipple in their mouth. So that can cause issues with latch. Some babies have a weak suck, but this is a baby who is latching, but she needed a nipple shield. She was at a very low tone and could not latch efficiently at the breast on her own. So the mother needed to use a nipple shield to provide that form teat for the baby. But sometimes babies have low tone. Maybe they are malnourished. A baby who's malnourished can have low tone. Anytime a baby is not getting sufficient milk, that's going to lead to more problems with their ability to suck. They may be jaundiced. A baby who's jaundiced, usually they're jaundiced because of lack of milk. And then the jaundice itself causes sleepiness and lethargy and poor tone. So it's kind of creates a cycle. Or the baby may not latch efficiently because of tongue tie or things along that well. So some babies they can latch, but they have a disorganized suck. So rather than having that nice coordinated suck, swallow, breathe pattern, they have a very erratic sucking pattern. So when you're doing a feeding session, you want to observe and listen for the sucking pattern. And a disorganized suck could be caused by a baby who's just early, a premature baby, or a late early term baby, or a late preterm baby, a baby who has a heart abnormality, who doesn't have the energy and gets fatigued really easily, a baby who has any kind of neurological problem. Oftentimes they have a very disorganized suck. Or even delaying the first feedings can lead to a disorganized suck if the baby has not imprinted properly at the breast. Sometimes there can be oral anomalies. So I'm just going to quickly go through these. I'd love to have us come to the chat box to share, but I realize our time is nearly gone. The top left, obviously, is a baby with a tongue tie. The baby in the middle here has a feeding tube. You can see that feeding tube into their mouth, but this baby actually has a cleft palate. And this baby had a lot of feeding issues and could not suck appropriately. The baby on the top right has a cleft lip. This baby, it might be possible for this baby to maintain a fairly decent seal if the parent kind of takes their fingers while the baby is latching and brings the edges of their lip together. They might be able to form a good seal. That's something you could try. If they cannot, then we may have to look at alternative feeding methods until the baby is able to get that repaired. The baby on the bottom left is a baby with Pierre-Robin syndrome, very, very deeply recessed jaw. This baby also had a cleft palate. So I want to remind you, babies with Pierre-Robin, and sometimes you see both the recessed chin and you see the cleft palate. So just be aware that those two can occur. Whatever causes the one genetic anomaly can often cause the other. So just kind of be aware of that. The baby in the middle on the bottom is a baby with macroglossia, so a baby with an excessively large tongue. This baby, I don't know this baby, but this baby would have required a occupational therapist to provide some resources and teach the parent how to do some sucking exercises to get that baby to latch. I've worked with 2 moms now whose babies had macroglossia, and it was a challenge for both of them. They worked through it. They both required the use of an OT, and that was enormously helpful in dealing with that issue. And we have seen our baby with torticollis here as well. So in terms of assisting moms, the main thing I want to talk about are a few tips, which one is to simply vary the position, try something different. If the baby is mad and upset in the football hold, then we'll then put the baby in the cradle hold. try putting pressure in another way. Maybe the baby has some birth trauma and is in a lot of pain from the birth trauma. So, don't rule that out. I had a mother one time whose baby screamed when she brought him to the clinic at WIC. She said, I want you to see what happens when I try to feed him. And I mean, the baby was crying, and it wasn't just the baby crying because he's hungry. She said her mother-in-law told her she was starving her baby. That's why he was crying. But, you listen to the cry, and sometimes that cry sounds not like a hungry cry, but it's a cry of a baby in pain. And I said to her, I'm really concerned about the pitch to your baby's cry, and I'm concerned your baby's in pain. I would recommend actually you take your baby to your provider and ask the provider to do another really good exam. She said, well, the doctor on call was actually an intern or resident who did the initial exam, and he said the baby was fine. But she took the baby to her regular provider, and they diagnosed a broken clavicle. So you never know what might be going on. So sometimes trying a different position will work, but if you suspect something more serious, don't ever hesitate to make that referral. Supplementation might probably be needed in a baby who is not latching well or effectively, or who refuses to latch. If they can't latch at all, then a tubing device isn't going to be helpful, but another alternative device may be. This is a picture of my granddaughter who developed oral aversion after the birth when she was suctioned 4 different times to get rid of all of the mucus, 4 different occasions over the first 24 hours of her life. And she wasn't having it. I don't care. She didn't want nothing in her mouth at all. And so we taught my son how to use a very, very, very narrow syringe. And he just barely placed it in the right the corner of her mouth, and she accepted the milk that way. And you can see that bright yellow colostrum. My daughter-in-law was over there pumping, and he was immediately feeding that to the baby. And we transitioned her back to the breast through stages. We started with this really narrow syringe. We then went to a bigger syringe. We then went to finger feeding, and then my daughter-in-law would do finger feeding, holding the baby right next to her breast while she finger fed. And then after about 3 feedings of finger feeding, she would finger feed and then pull out her finger after the edge to the hunger was taken off, and then latch the baby. And it took about a day and a half, but we got that baby back on the breast, and she breastfed a very long time. So transition, think about how can we do this in stages in a way that will be palatable. Monitor the baby, monitor wet and dirty diapers, weight gain, all those kinds of things, and certainly make your referrals as needed. And I'm sorry that that's all we have time to cover in that section. I do want to close today with a couple of things. One thing I'd like for you to do is to come to the chat box and tell us if you could give any gift to your participants. I don't know, whatever that gift would be, tell us what that one gift is that you'd like to leave them with. We'd love for them to all be successful with breastfeeding, but is there anything that we want to make sure that we leave them with, whatever that may be? Put that in the chat box. I think it'll kind of help us bring us full circle in talking about our counseling skills during problems. And I'd like to bring us full circle with sharing a story of this mother. Her name is Sarah. She's actually a very, very good friend of mine. She's my neighbor. She lives across the street from me. She saved the life of my husband on multiple occasions. He would not be here with us if it was not for Sarah. And she tells me she would have never been able to breastfeed without me. So the two of us really developed a bond. And she's also a photographer, in addition to being a physician. And she shared some absolutely beautiful photos she had taken of herself with her baby. And she's also a wonderful writer. And she shared her story with me and gave me permission. She actually wrote this out for me to share with you. So I want to share Sarah's story. And these are her words. She said, as a family medicine physician. I am trained to care for people in all ages and stages of life. I was trained well and mentored by some of the brightest physicians I know. While I am forever learning, it is not often that I come across areas where I feel I have a big knowledge gap. Recently, one of those gaps became extraordinarily apparent: the mother-baby dyad and breastfeeding medicine. I always knew that I wanted to breastfeed, and I was acutely aware of the health benefits, especially in the setting of the pandemic. What I did not imagine is that something that I thought would be natural would end up feeling so unnatural. Maverick was born ready to suckle. We spent a glorious 2 hours together after the birth. Everything seemed perfect. I was able to express colostrum and he latched like a champ, though I quickly became quite sore. He was sleepy, but we woke him to feed often. We logged his wets and dirties, but looking back, I can see just how yellow he was on day 2 of life. But I was so blinded by love and exhaustion, I didn't notice. On day 3, his bilirubin was way up and his weight was way down. By day 4, the doctor recommended formula supplementation. I cried. I felt like my body had failed both me and him. But at the end of the day, I knew he needed to grow, and we did what we had to do for him. By day 6, a lactation nurse at my OB office introduced me to the wonderful concept of triple feeding. This meant every time Maverick is fed, we would pump after the feeding and then feed that to him along with additional formula if I was not producing enough. It was exhausting. Initially, I pumped mere drops. When I would take all day to fill a 6cc syringe, I would celebrate. I was proud of our progress and I thought, we're finally getting the hang of things. And then came the visit we least expected. Despite working tirelessly to build my production, Mav was still not gaining weight. At 2 weeks, the pediatrician suggested we use formula only for the next 24 hours and not give any breast milk at all. When I tell you I cried, I actually sobbed for an entire day. It seemed the journey that I wanted and had prayed for had come to an end. But I met with a hospital lactation nurse who saw my heartbreak and empowered me to make my first firm decision as a mama. I reached back out to the pediatrician and told her that this was not a solution we felt was going to work for us. I then reached out to my good friend Kathy, and she encouraged me to consider a care plan that would enable me to continue keeping Mav at my breast. The pediatrician agreed with the alternative plan and said she did not realize there even were any breastfeeding resources in the community. Then I learned how to use my pump more efficiently. I held Mav more skin to skin. I began using a supplemental nursing system Kathy provided me, which cut out one of the steps in the triple feeding process and enabled Maverick to receive his nutrition at my breast. We saw a pediatric dentist to assess his lip and tongue tie, and we agreed to the revision, which brought immediate improvement in his latch and my comfort. An infant bodywork specialist gently addressed his tight mouth. As the milk I pumped slowly began to increase, I began to feel reassured that this journey, albeit still not remotely easy or natural, was not going to end after all, but rather to change. And then I noticed that Mav began wanting to be at my breast more and more, just for comfort. We began to bond. My production at 4 months is still not completely sufficient to fully breastfeed him, and we do need to continue using donor milk to fill that gap. But I have finally been able to move away from the idea that my body and I were failing my baby. When sometimes I find myself still feeling that way, I just look into the eyes of my sweet baby and realize whether it's my milk, donor milk, or formula, all have contributed to helping him become nourished and healthy. There is no longer failure in this journey, only success. My body is healing, and best of all, my heart is healing. I'm now back at work where I pump every 3 hours, and finally, breastfeeding is feeling natural. I truly savor our special feeding times. It has been the hardest and the most rewarding thing I have ever done. And it has been done with the support of my husband, family, medical team, lactation team, friends, fellow mamas, and online support groups. It truly takes a village to raise a child. And if this journey doesn't prove it, no journey will. I'm very teary-eyed right now just sharing this story because I've been with her through thick and thin. And this is a lady, guys, who was so empowered and assertive and accomplished as a physician that she was Mississippi's Physician of the Year, her first year practicing. And yet, despite being empowered, all the emotions come up there when you're a mama, right? Everything changes. So I'll thank you for allowing me to share that story, and thank you for allowing us to be a part of your lives over this last week. Thank you for sharing your stories, your perspectives, all of your good wisdom, and thanks for all you do for the WIC families that you serve. We are enormously gratified and appreciative of each and every one of you. And I hope you'll keep in touch in the days and weeks and months to come. It's now time to say goodbye, so I'm going to turn it over to Melissa and to Rachel to wind us up. Thanks, everybody.
Thank you so much, Kathy. All right, so these are the items that you can check off on your WIC Action Journal for today for session 4C under counseling, difficult counseling situations, under problem solving, supplementation, low milk production, complex maternal problems, and complex infant problems. Don't forget to complete the survey that should pop up for you when you leave this meeting. If it does not pop up for you, please send me an email at melissa@everymother.org and I will get that to you, the link to you. All right, and I will turn it over to Rachel now. Rachel.
Hi, thank you so much. I just want to thank Melissa and Kathy for helping and supporting Washington WIC staff by presenting this training. It's so much good information, and we look forward to working with you again in the future. So thank you very, very much. And to everyone else, as I said earlier when we started, I just want to have a couple of tidbit things to share. First of all, we just so appreciate each of you coming and sharing so much of your wisdom, which we don't get to hear a lot of. So it's great to be able to hear your stories and hear your experiences and the WIC community. But we want to remind you about the listening session for the new curriculum. We want to hear what thoughts you have or questions you have, and we may not be able to answer everything that day, but we will be able to take that information and be able to compile how we're going to move forward. And if you're not able to make it to the Wednesday, May 31st listening session, please send your questions to us so that we can make sure that your questions are posted for that. And then I also wanted to share, so we know this is a wealth of information from this training. You are not alone. We're not like, okay, go be free. We will be working on ways to support you and train a trainer and making sure that you're not left alone with all this information. So please stay tuned. We're going to share more in the coming weeks. So thank you so much. Don't hesitate to reach out to Leslie Hughes or myself, and hope you have a wonderful rest of your day. Take good care, everyone.